All right, welcome everyone to another healthysimulation.com webinar. We have a few more folks that are joining us right now, but we're going to go ahead and get started with this presentation. If you have any questions during the event, please feel free to put those into the chat room. I'll be following along with them here. I'm so excited to have with us Suzanne Gordon, who is a prominent author in the field of patient safety. I've had an opportunity to meet with her on several occasions and just find her to be a complete a jewel in terms of the amount of information and knowledge that she has with regards to the space of translating patient safety, medical errors, and looking at other industries and communities and relaying that research and that support back to us in healthcare in terms of the things that we could be doing to make for improvement. So she has written over 21 books, including First, Do Less Harm, Confronting Inconvenient Problems in Patient Safety, Beyond the Checklist, What Else Healthcare Can Learn from Aviation Safety and Teamwork, one of my favorites. I absolutely love that book. I think it's brilliant. Collaborative Caring, Stories and Reflections on Teamwork in Healthcare and Wounds of War, How the VA Delivers Health, Healing, and Hope to the Nation's Veterans. She's also the co-editor of the Culture and Politics of Healthcare work series at Cornell University Press. And her work has appeared in JAMA, JMA, the Annals of Internal Medicine, the British Medical Journal. And I know that she also has some work in with the kind of playwriting. I know that there's an awesome play that she's written, and she can, I'm sure, tell us more about that in terms of patient safety, which I think is doing things beyond the book in terms of conveying these important messages. So today, so excited to have her helping us to present on how to maintain patient safety during a pandemic, positive lessons from the VA. So Suzanne, so excited to have you with us here. Thank you so much.
Thank you. I'm really excited to be talking to all of you. I have spent 35 years or more writing about healthcare, notably about healthcare systems, teamwork, and particularly from the vantage point of non-physician professionals and also non-physician healthcare workers. And about 10 years ago, I got interested in what the VA was doing about teamwork training, because they really have been one of the leaders in patient safety, and they really take teamwork training seriously. So what I found in a lot of other hospitals and healthcare systems was that teamwork training was really, lip service was given to it. The model was very much train the trainer, but people were not really well trained in teamwork. In the aviation safety movement, which really started the high reliability industry's emphasis on teamwork, you had dedicated trainers who were basically, that's all they did was train airline staff about how to work on teams and how to function on teams. And in most hospitals and healthcare systems, it's very much a go do team steps and then watch it being done, and then go back to your institution and train people. When you've never done a training before, you may not have any familiarity with this material, and so it really doesn't work very well. And often people, in my view, got chewed up by people who were resistant to working on teams, and really didn't have what I call team intelligence, which is a concept I've developed in part because of the aviation safety movement. And I began to learn that at the VA, the Veterans Healthcare Administration, that they really take it seriously. They just do it in every way they can. And I began to look at the VA because I was interested in its teamwork, and then began to write about VA healthcare. And I don't know how many of you know much about the VA, or if any of you have worked there, but let me just tell you that what you read in the newspapers is not the truth. It actually is fake news. And the VA happens to be one of the best. It is certainly the largest healthcare system in the country, and it's one of the best on many measures, which I've written about in Wounds of War and elsewhere. Can I have the next slide? And we've really seen its excellence in the pandemic. So let me just say that what I'm going to talk about is that when it comes to a national crisis, which we have, and we're having a worse surge now, as you know, than we had in March, it really helps to have a national health system. And the VA is a unique model with a lot of important lessons to us. It's a universal healthcare system for a small but vulnerable segment of the American population. The VA, so what we call the VA is the Department of Veterans Affairs, and it has 4 sub-agencies, the largest of which is the Veterans Health Administration, which has about 300,000 employees and cares for about 9 million eligible veterans. Only veterans who have service-connected disabilities or and or who are poor, low income, or indigent are eligible for VA care. And so it's really interesting when you look at the lessons from the VA in COVID and the lessons of the VA and best practices of the VA in general, because the VA essentially cherry picks the sickest, poorest, and oldest patients. These patients are extremely complex. The average Medicare patient has 3 to 5 presenting problems or comorbidities. The average Vietnam vet has 9 to 12. An Iraq vet could have 16 presenting problems, both physical and emotional. Many are low income. I mean, the point is you can't get into the VA if you aren't sick or poor, and the average age is 62. So the VA delivers comprehensive health care to this very vulnerable population at a way lower cost than the private sector. The VA has the Veterans Health Administration, which is what I'm going to talk about, has 4 missions. It delivers clinical care to veterans, 1. 2, it is the biggest research powerhouse in the country. It does research. Thank you, VA, for my shingle vaccines, the nicotine patch, first implantable cardiac pacemaker, research on genes and health. The 3rd mission is teaching. 70% of American physicians in training are taught in the VA, psychologists, nurses, occupational therapists. And the 4th mission, which I'll talk about in a minute, is to serve as a backup to American healthcare system in a national emergency, which is what we're facing now. Fundamentally, and this is critical for us to learn in best practices in COVID, is that its incentives are almost entirely different than the rest of the US healthcare system. It's mission driven, not profit driven. Its facilities are government owned. Its employees are, its staff, doctors, nurses, everyone is an employee. It's not fee for service. So it's not concerned with the steady stream of fee for service revenue. And this makes a big difference in a healthcare emergency. Could we have the next slide, please? So I talked about the 4 missions, sorry. And so it's interesting because, again, most people, you know, before I started writing about the VA, I was like, I mean, I don't know who's on the call or who's listening in, but I was probably like most Americans, like most doctors, most nurses. You know, I knew the VA was there. I mean, you see the sign VA hospital, but I had no idea what went on there. And I had no idea that the VA did research that benefits us all. I had no idea that so many doctors and nurses, psychologists, you name it, went through the VA system. And I really didn't know that the VA specializes in what the American healthcare system does very poorly, primary care. We have a major problem with primary care, which is exacerbated under COVID. We're finding now that one out of 4 or 5 primary care practices and doctors are going out of business. We have 7,600 geriatricians in America for 30 million elderly citizens. We have a mental health system that is really at the state of collapse. I mean, essentially in America, prisons and jails are our mental health system. 55% of American counties have no psychologist, social worker, or psychiatrist. All 55 there, and most of them are rural. 70% are sort of mental health deserts. The VA specializes. It's a primary care based system. It practically invented geriatrics. In fact, geriatric care is a critical part of VA. They have an amazing geriatric primary care system, and they have an incredible home-based primary care system. Mental health care in the VA is really practically second to none. It's very coordinated. And one of the things the VA does is it delivers integrated care. Now, I never knew what integrated care was until I started hanging out in VA systems, because as an American patient, I'm my care integrator, right? I mean, I just had a virtual visit yesterday with my primary care doctor, who had no idea that I had cataract surgery, right? And I was I'm the care coordinator, right? I have to coordinate care. I don't know how many of you read the Steve Jobs biography by Walter Isaacson, but when Jobs was dying of pancreatic cancer, his wife had to assemble all the different, the cardiologists, oncologists, you name it, is around his bedside to get them to talk to each other, because they don't talk to each other in the private sector, right? And of course, he was Steve Jobs, so she could kind of, snap her fingers and promise Stanford a new wing and get them to talk to each other. So in the VA, and this is really critical for lessons for COVID, you have integrated care. These people actually talk to each other. I mean, they don't just put notes in a chart. They actually talk to each other about their patients. Novel idea, right? They have they also have a population base. There's services for the homeless, employment services, legal services for veterans who have problem with the law. And another extremely critical thing, and this is absolutely critical in COVID, is that they have high quality nursing home care. Every large VA has what's called a community living center, which is their nursing home. They have better staffing, better pay, and we'll go into this a little bit later. And again, I want to return to the coordinated care, because essentially it's not just that people talk to each other. For example, on a primary care unit, you have a psychologist, a psychiatric nurse practitioner, a social worker, a dietitian on the unit right there. So if you have a patient who has a mental health problem and is saying, I feel depressed or whatever, you don't write a referral for an appointment to which they may not make or ever go to. The primary care doctor or nurse practitioner will walk the patient down to the mental health practitioner, and they will initiate that practice right there. Same is true with dietitian. Same is true I didn't mention pharmacy on the unit. So you really get an incredible coordinated care, which is why the VA has, according to studies, countless studies that never get discussed in the press, why you have so much better outcomes with heart failure, according patient safety, behavioral health program, et cetera. So you have I could do an entire presentation on the studies that come out. And by the way, for less money, way, way less money. So if we could go to the next slide. So you have, as I said, home-based services, and this is really important. And I began to talk about this in the beginning. You have real teamwork. Now, I did a video, and I'm sorry, I should put it, it's on my website. It's called How to Huddle. And this is a discussion of how the VA created huddles for primary care, and they use it elsewhere. And these are not your usual huddles. These are huddles that are designed to make sure that non-MD voices, that the non-usual suspects, who often have a great deal of information about the patient, are heard. And so in the huddles, in the VA, it's not the attending physician or the doctor that runs the huddle, it's the clerk or the LVN, licensed vocational nurse, or the nurse. And it's an occasion not only to build teamwork, but to really create an opportunity for all voices to be heard. And they have now, under COVID, gone to virtual huddles, which is extremely important. And this is, again, why you see these incredible outcomes. One of the outcomes that we've seen in this COVID emergency is that the healthcare disparities where African-American and people of color are dying in greater numbers, we do not see that at the VA. We see there is disparities in testing, but not in deaths. So why do we not have these kind of huge healthcare disparities in the VA? Well, because the VA's advantages as a not-for-profit national system were triggered immediately and came into play as soon as the pandemic began. The VA immediately acted to cancel in-person appointments to protect patients and staff that were non-urgent, right? And they could do this because they aren't fee for service. So was a revenue neutral decision. The VA doesn't get paid on the basis of how many procedures are performed or how many visits there are. It's capitated system. So they have a budget. So if you see you're not impacted in your revenue stream if you cancel in-person visits. And I talked to, for example, one VA chief of staff who said, I feel so lucky to be working in the VA because I can cancel these appointments. And the hospital across the street, which is for-profit, is still doing appointments because it's going to kill them, their revenue stream. They immediately mobilized telehealth, which is clearly in the bailiwick of Health vSim, to reschedule appointments. The VA has long been a leader in telehealth. They didn't have to ramp up. They were already a global leader, and they rescheduled appointments in everything from mental health to audiology to everything. And they also they have 3 telehealth ICUs, which they utilize to provide extra help for the ICUs that are overwhelmed in hotspots like New York, New Jersey, Louisiana. They immediately transformed ICUs into COVID wards and inpatient wards into COVID wards. As I said, they canceled elective procedures and surgeries, and they immediately acted to protect nursing home patients. If we can go to the next slide. They shifted staff as needed. Now, because they're employees, you could tell a orthopedic surgeon to do COVID testing, whereas in the private sector, 50% of doctors are private contractors. You can't tell them where to work. So there was a tremendous shifting of staff, and also a sharing of staff, sending staff to help in VA facilities where needed. So they went into facilities all over the country, New York, New Jersey, Louisiana, et cetera. They shared information. They have in their headquarters, they have a command center, an HOC, Headquarters Operation Command, where they have real-time information about every VA facility in the country. So they can share information. They had a very bad time in the beginning with personal protective equipment, like everybody did. Actually, FEMA, the Federal Emergency Management Agency Administration, did some very bad things to hurt the VA. And actually, the VA made a decision under Bush 1 in 1991. The VA had its own supply depots, and they went into this just-in-time supplying mode and got rid of that, and that hurt it too. And so basically they were dependent on the national supply chain for personal protective equipment, but they quickly ramped up, and now there are enough supplies. And as I said, there are no disparities in fatalities in the VA because of the care coordination, because people with chronic illnesses, they have them. Veterans have many more chronic illnesses than the average patient, but they get coordinated care. So we haven't seen those disparities in fatalities. Can I have the next? This is absolutely critical. So most people have no idea that the VA has a fourth mission. Most people don't know what the first three missions are, but they don't know that the VA has a fourth mission to serve as a backup for civilian sector healthcare system in a national emergency. And I've seen this when I've covered the VA I was in, I can't remember, 2014 in Hawaii. There was a volcano in eruption, and the VA immediately went into action to make sure all patients in the VA had their meds, had their medical equipment, could make it to appointments, could do telehealth appointments, and they set up a command center in the VA. They did the same thing in California wildfires, calling every single patient who was affected to find out if they were okay, what they needed, and so forth, and attend to their problems. And then 6 weeks later, they called them back to make sure they're okay. I don't know about the folks on the phone call, but I've never got a call from any of the health systems or insurers that insure me or take care of me to find out if I'm okay. And we just lived through the fourth horrible California wildfire season where we couldn't go out of the house, open our windows. It was pretty awful. In Hurricane Maria in Puerto Rico, the VA hospital was the only functioning hospital on the island. And so it took care of all patients, not just veterans. And in COVID-19, the VA immediately put its fourth mission into action. Could I have the next slide? It sent staff to New York, New Jersey, and Louisiana in VAs where there were hotspots, because the VA opened its units to non-VA patients to help them where these hospitals in these hotspots were overwhelmed, and it's doing that right now. It sent staff into nursing homes in North Carolina, Arizona, and other states. It actually took over the state veterans home in North Carolina. And it's in Hawaii, I believe, where these homes were run by for-profit nursing home companies that were endangering residents' lives. And of course, it made hospital beds available to non-VA patients. Next. The lessons from VA nursing homes are critical. Now, we know that the nursing home situation before COVID in this country was what my friend Charlene Harrington, who is a major long-term care nursing home expert, has said. It's almost a human rights issue without COVID. In COVID, nursing homes, as you know, have become a disaster area. And for-profit nursing homes do not pay their staff enough. They do not train them adequately in infection control. They do not provide them with personal protective equipment. These nursing home aides are paid so poorly that they have to work 2 or 3 jobs, that they're going from nursing home to nursing home, spreading the virus. They can't afford to take time off because they don't get sick leave if they're sick. And in the VA, that is not true. They have very good benefits. They have very good sick leave. They have very good pay. They work there. So, and there's a lot registered nurses in VA nursing homes to do training and so forth with other non-RN staff. So the VA began with an advantage. The minute COVID became clear that COVID was going to not be great, to say the least. They immediately closed down nursing homes to visitors. They sent out residents who were being rehabbed, who were, didn't have to stay. They moved from 2-person rooms to 1-patient rooms. They closed down their CLCs, their nursing homes, to non-nursing home staff. So in the VA, the dietitians would bring the food into the CLC. Other staff would come in and out of the CLC. Nope, that stopped. The dietitians deliver the food to the door, and the staff in the CLC take it. They were better. The pay and better staffing meant that there weren't spreads of infections, and there was no churn. And there was way better infection control training. In fact, as I said, so much so that the VA has sent staff into for-profit nursing homes, not only for veterans homes, but in other nursing homes in other states. And this is really critical because if we don't get the situation in the nation's nursing homes under control, we are going to have trouble moving forward. And this will not be the last pandemic. I wish it were. I wish we could all just go out and hang out in bars and go to concerts and, do in-person discussions. But this is the beginning, not the end of this. And we need to learn these lessons so that nursing homes don't become, ground zero for infections or super spreaders. The next one, please. And please forgive I'm embarrassed to be with a bunch of people in technology and be so bad. I actually covered this, but I just want to say that this move in the VA to telehealth is very interesting because there is no penalty to less affluent patients. One of the big problems that you have with telehealth is you have to have the devices, right? And that means you have to buy the devices. Well, a lot of folks, particularly if they've lost their jobs, they don't have money to buy iPads and Wi-Fi and so forth. And VA has always given devices to patients gratis. So these are considered prosthetics. They give these patients the wherewithal to do inpatient monitoring. They've always had the capacity to do in-home monitoring. They've had a very robust in-home monitoring system for blood pressure, blood sugar, et cetera. And this was just ramped up under the coronavirus crisis. So if we can have the next one. And again, so I think it's worth going over the issue of healthcare disparities because we know that patients with chronic illnesses have many more disparities in the private sector system than in the VA, and that they suffer more. Now, what is really interesting about healthcare disparities in general and in the discussion of healthcare disparities is that often the idea is that if you have more chemotherapy, more cardiology meds, more whatever. Healthcare disparities, a lot of people who are not educated in healthcare think that it's bad that you need more of everything, not more of just some things. And we do see healthcare disparities in the VA. But interestingly, they often benefit patients because patients are getting less chemotherapy, and it's not necessarily great to have the 5th or 6th round of chemotherapy if you're dying of pancreatic cancer. What you should get is palliative care, which is what veterans are offered in the VA. It's not necessarily the best thing to have polypharmacy and to get more drugs. And what we see in the VA is there is very little incentive to provide too many medications, which we know that in one out of $7 in the American healthcare system goes to unnecessary pharmaceuticals. So it's really interesting that in the VA, often what you see is that people are getting appropriate treatment, even though they may be getting less treatment. And this is certainly true for geriatric patients, which is also why there's fewer healthcare disparities, because you have geriatric primary care physicians that are monitoring the appropriate use of medications and pharmaceuticals in the older patient. And as we know in the private sector, very often when a patient finally gets to a good primary care provider or geriatrician, one of the few that are there, when the patient comes in with 20 meds, one of the first things the doctor does is take away, 16, because they're just not necessary. And so you have a much greater control of appropriate use of medication, which is another reason why you have better outcomes in the VA and why you have better outcomes under COVID. If we could have the next slide. So, the really important lesson here, and this just can't be overstated, is we need a national healthcare system, in my view, to respond to a national emergency. We need people to coordinate care for sick people. Now, one of the things that's really important in the VA is that many of these veterans, as you know, suffer from mental health problems. They suffer from PTSD. They suffer from major depressive disorder. They suffer from schizophrenia and bipolar disorder. It's quite interesting that you see a very large population of veterans who have schizophrenia and bipolar disorder. Why? Because they go into the military when they're 17 or 18. And so this is precisely the time, in late adolescence and early 20s, when schizophrenia and bipolar disorders appear in this population. So these are people who have trauma, who have mental illness, and many people with physical illness. These people cannot coordinate their own care like they do like they're asked to do in the private sector system. If you have an Iraq vet may have 16 different presenting problems. A friend of mine who's an Iraq vet has 16 different presenting problems. He can't coordinate his own care, and the VA does this. So when you have a national system with coordinated care, where people actually coordinate the care for the patient and with the patient, you have better outcomes. And that's what we see in the VA. And when you have better management of chronic illnesses, right, you have better outcomes when you have a novel virus like the coronavirus. So I think we need to look at the VA to follow its best practices, nursing homes, primary care, geriatric care, mental health care, care coordination and integration, and also the coordination that comes when you have a national system that can share staff, share information, share supplies, and that also has a mission to help the larger population. So I think these are the major lessons learned and the best practices that we need to follow from the VA. And I'd be glad to answer any questions that anybody has.
Well, thank you, Suzanne. I really appreciate the overview. I think it really demonstrates to me that there was a kind of a strong response to COVID from the VA, and a coordinated response and an effective response, which, I think is a story that we are missing, in some of the media right now, not only about the VA, but other healthcare systems that are performing and how they're performing well during this difficult and challenging time. So I think that that's really helpful for us to understand and to better learn more about. A couple questions have come in from the audience. I'm going to start with my own question though. Do you have any idea if simulation or how simulation in terms of PPE training or virtual training has been effective or utilized in any way by the VA in the last in this year?
I should have found that out, and I don't. I know that the VA has one of the largest medical simulation centers in the country, Orlando, Florida, and that they use medical simulation, and
Yes.
I'm sure they have. And I'd be happy to try to find that out for you. But like I said, they have gone to virtual training of staff in how to use everything. Like they've gone to virtual team training, they've gone to virtual huddles. And so, they really, I think what's interesting, because the VA has used simulation so much, and also because the VA has done teamwork so much, that, it has it has established a foundation. And then when you establish a foundation that is quite firm and a really firm commitment, for this, then when something like this happens, it's kind of like, I live in an earthquake zone, right? And I live in, thank God, knock on wood, I live in a place that has bedrock, right? I'm on bedrock. So on bedrock, yeah, things shake a little bit, but if you live in the marina and you're on sand, it just vitrifies. And so I think that the fact that it's in a crisis now, I'm not sure I should say this on this call, but the Trump administration has really tried to harm the VA's capacity and infrastructure, and hopefully in a new administration we can re-strengthen that. But even in spite of Trump administration efforts to cripple the VA, the foundation that has been established in simulation and team training has been utilized and built on. And so it's not like it just sort of disappeared. Oh, well, now we have an excuse. Oh, we can't do this now because, we're too busy to be focusing on other things. And I think when it comes to team intelligence training, which is what the VA at its best does, not everywhere, but when it comes to this team intelligence, that just goes virtual, you know what I mean? It just goes virtually viral, as opposed to, and so that's another lesson learned. But I'm really sorry, I can't answer that, but I'm sure that happened and I can find that out.
No worries. Yeah, just curious about that. I did share the link to SimLearn, which is the VA's Orlando Simulation Center, as well as they themselves also had a link to the VA COVID-19 training resources links page. And I've shared both of those links in the chat room. So I think that those would be very interesting for the participants to check out.
And can I just say one thing? That
Yeah.
everything the VA produces is public.
Mm-hmm.
And there's nothing proprietary, when they they've developed these fabulous apps, PTSD, insomnia, cognitive behavioral therapy apps, and all of that is public. It's a public system. So they don't, keep anything a secret, there's no proprietary competitive advantage that they're trying to play on. And I think that's extremely important.
Absolutely. Yeah. I think it enables for, it's from the public for the public in a sense. And so to have access to those resources, I think makes sense because it's not a private company. So lessons learned should be shared because it's invested in by the public in terms of tax dollars. So one question that came up from Jonathan, was the VA limited in any way by the federal government in its response to COVID? You kind of mentioned something about the Trump administration. So if you wouldn't mind just sharing a little bit more about what those challenges were.
Well, the VA was limited by prior decisions. The Bush administration, as I said, they used to have their own depots where they had their own supplies and pharmaceuticals. And so that was in 1991, a bad decision in my view that was made, but that was in the interest of, kind of a privatization and using a private sector model, this just-in-time model. Under Obama, the headquarters command center was abolished. And they actually under Stone, this was one good thing that the administration did. I think he did it under the radar of the Trump administration, quite frankly, was to bring that headquarters command center back into operation. There was an effort by the staff at the VA. Various doctors and nurses were asking the National Center for PTSD to give guidelines and the standardized guidelines for how to use masks and help veterans be comfortable with masks. And the National Center for PTSD produced those guidelines, and the White House forced them to take them down off the website because this went against Trump's policy. So that was something which was not very good. And of course, you know, the Trump administration and even the Obama administration was committed to more outsourcing of VA care. So when the VA appropriately stopped sending veterans into the private sector to protect veterans, there was an outcry by conservatives in the Trump administration about that. But they held fast to that. They then, you know, when things looked better, they started sending people out again to the private sector. But now that we have surges, we hope that the Biden administration will halt that program again. I just want to mention, and I'm sorry that I didn't put this on my slide, but I am the co-founder of something called the Veterans Healthcare Policy Institute, which is veteranspolicy.org. And if folks want to go to that website, veteranspolicy.org, they can learn more about the ongoing issues with the VA. I'm curious, are any of the folks online, do they work in the VA or have they worked in the VA, or is that appropriate to ask? Or?
Yeah, I mean, I think we can ask. I'm not quite sure, you know, and we'll see if we get any responses from folks on that. I would assume probably not, since they want to learn how the VA is being effective, and so probably they're probably from what's up. I'm just going to paste in that veteranspolicy.org link as well that you just mentioned too.
And there's a weekly newsletter, and you can subscribe to that for free. And I think that you might learn more. We really need to learn more about best practices from the VA. Mm-hmm. And sadly, the media has been on a bit of a journalistic anti-VA bashing trend, or essentially been doing that for the past 4 or 5 years. So really what you learn about the system is not correct.
Okay, that's good to know. Yeah, that veteranspolicy.org looks really helpful for those that are interested in kind of getting ongoing updates from the VA, or rather about what the VA is doing in terms of what could be happening there and what is happening there. Next question that came in from Bob. Do you feel that COVID-19 will make telemedicine a permanent part of the VA's care plan moving forward?
Oh, yeah, but it always has been. So I mean, it's really, like I'm saying, the VA has used telemedicine. I mean, way before COVID, I sat in on this was years ago, I sat in on an appointment between a PT in North Carolina and a veteran in White River Junction, Vermont. I sat in on an audiology appointment with a veteran in Honolulu and a VA in San Francisco. So they've been using this a lot, and they have a big problem because they have so many veterans. Like a quarter of veterans live in rural and often very remote rural areas. So, it's very important for them to use telemedicine. So I think, yes, I think they will be. So it's not like they have to, they will just be expanding, and they've done way before the COVID. They started doing studies, trying to find out if telemedicine was effective in mental health care. We're doing mental health appointments. I know I I personally, it's ridiculous. Like I moved from Massachusetts to San Francisco, and I had a therapist there who I loved, who I had a very good relationship with, who, I could have done, well, at that point it was less Zoomy, we didn't use Zoom so much, but there were, phone calls, right? And Medicare would only pay for the visit if it was face to face. That was absolutely ridiculous, right? I mean, it was helpful for me. I had a very good relationship with this person, and why couldn't I just talk to her over the phone or on, some kind of FaceTime? Nope, they wouldn't pay for it. At the VA, this was way back then, no problem. You could do your mental health visit on their through their VTEL. So yes, I think they will be continuing to use it, and I think people find it. I think they find these virtual visits to be actually sometimes more congenial. I did a virtual visit the other day with my doctor, and I was really impressed by how we suddenly had a shared space. He was in his space, I was in my space. And this was the only time I've ever in my 75 years experienced a sort of shared relationship with the doctor where the power dynamics weren't on my end in home care, where they were coming into my space and it wasn't me going into their space. And I think my blood pressure went down, like exponentially, and it was really wonderful. And I don't want to go back to in-home. I want to continue that, and I know the VA will continue that. But we are so not out of the woods.
Yeah, we've probably got at least 7 or 8 months to go. Summer of next year maybe, for the United States. And and I know from Bill Gates, he had suggested end of 2021 for developed countries, and undeveloped countries 2022, end of 2022. So certainly we're going to be dealing with these problems for quite some time with regards to COVID and the effects that it have. But it's fascinating to know that the VA was on kind of an innovative edge when it comes to telemedicine and having that infrastructure in place, and being able to enable for it in a way that wasn't limiting. And then they just expanded those opportunities during COVID. And so that's exciting, because I think it's probably going to lead to a catalyst like event of the utilization of that tool by more medical professionals. And I agree with you. I think it's more effective and more efficient, right? Like, unless it's something where we need to do a patient assessment directly with the patient in person for and obviously there are plenty of reasons for that. If it's just a back and forth dialogue that they would do like any other general assessment, where they didn't need a specific vital sign or sample taken right then and there, why not have that ability to kind of reduce the overhead of the scheduling and the process of all the costs involved with having in-person kind of brick and mortar visits, and alleviate some of those headaches by having telemedicine be a part of the conversation. So I think a lot of exciting developments there, that I think COVID will be pushing more, not just for the VA, but for a lot of institutions as well. Go ahead.
Yeah, I mean, I think that there needs to be studies done about, I think it'd be quite interesting to do studies about what this, I think the virtual modality really changes status relationships, particularly if somebody is, I guess, it's like you, Lance, sitting here, in your shirt and your cap, if you were at a conference, probably, I don't know, you probably wouldn't be wearing that, and I would be not in my backyard, and people wouldn't be seeing where I live, and you wouldn't hear the sounds of normal life, and there's something about this virtual environment that I think really helps. And as we know, these status differentials in medicine can kill people. So I think anything that you can do to reduce these kind of status differentials, whether it's like the way the VA does the team huddle or the way we relate on Zoom, it's kind of hard to have, I don't know, it's hard to do status differentials and in a virtual environment. I guess you could try really hard.
Yeah.
But I think this makes a really big difference in medicine,
Yeah. And I can imagine that the time will come when they'll be either at each home or with rapid availability within 24 hours notice of delivery, like Amazon 2-day delivery, but maybe VA 1-day delivery of a vital sign device to take key vital signs from a patient and receive those things, if that is an important part of, of an interview process with patients. And so we might either have these devices just automatically in our homes and it'd be attached to our computers, and it can take our blood pressure and our pulse and all those kind of things quickly and easily to give those additional, points of reference for healthcare providers when doing these, Zoom-based calls, if you will, for telemedicine. I will say that, we did a webinar with Dr. Kelly Bryant out of the Columbia University School of Nursing, and her team just demonstrated a lot of the really awesome tools that they were utilizing for their simulation program and education for nursing students now that COVID had, taken effect in 2020. And just in the last 6 months, a whole bunch of new technologies they've implemented, very innovative kind of program that's ready to move forward with, new stuff and isn't afraid of getting their feet wet with it. But they had suggested to me, Dr. Bryant suggested to me that these technologies are going to outlive COVID, right? So some of COVID will come and eventually, hopefully, fingers crossed, will go. And that some of the things that they've implemented for distance-based learning that occurred because of COVID, they'll be keeping those technologies after, because they're just actually more effective and more efficient. So I think in that sense, we do have this catalyst-like opportunity that's taking place now in healthcare simulation and ideas of education, training, and patient engagement that are going to have a lasting impact. I think of, just look at how many people are now using Zoom, right? And how it's become kind of, it's like Kleenex versus tissue. We're now Zooming people all the time, right? So Zoom has become a term like Google that means what it means in terms of communication and engagement. I think that has, while it was existent before, Microsoft Teams and Google Zoom, these things have become really prevalent this year, and I don't see them going away. I've heard from several companies that they plan on doing more of this at-home, work-from-home type style of business operations because it's just more efficient and more effective for them. And so I think it's kind of provided for an aha moments, which I'm excited to hear about it happening with the VA too.
I think that the VA has always used these in-home monitoring systems. And for example, they have in most VA medical centers, they have they have been monitoring blood pressure and various other vitals for chronically ill veterans. And that's another reason why they have done very well in the management of chronic diseases. I do want to point out that when we do have to recognize when we do at-home work that not everybody is privileged to have the space to do that. And so, if you have a poor person or a person who's not making a lot of money and they live in a place like New York, San Francisco, and they live in a tiny apartment and they can't set up ergonomically. We have to start thinking about that and building, this. If companies are going to save money on rent on office space in downtown San Francisco, then they have to put some of that savings into making sure that their workers can afford affordable spaces. And I agree with you. I think this idea of commuting to work, I live in San Francisco and it is a joy, not to have to be on the highway for 3 hours. And, people are suddenly realizing that, they don't have to be at work to do work, but we do have to protect workers from the difficulty of setting up ergonomically correct and also socially acceptable in-home offices. It's one thing if you have a big house and you can have your own room. It's another thing if you have 3 kids and, so that needs to be really taken into account.
I had myself muted. I said, absolutely. Yeah. I think, access to this, especially when we come to the public sector in the VA, how are we going to make sure that veterans are going to have accessibility to these new tools and enable for that? I think even goes as far as at what point do we suggest that internet and connectivity to the web is just a right and not a privilege, right? In terms of, accessibility. So, if gaining access to the airwaves for radio and television, well, why not internet too? And, that's all going to have a long-term impact on these opportunities for providing at-home care regardless of whether it's private or public sector. Okay, so last final question I saw, Susan, just so you know, we did go ahead and share some of the links to your books pages on Amazon as well, so people can learn more about that there. Fantastic books. I really absolutely highly recommend all of them, especially the Beyond the Checklist one. That one is one of my favorite books, and I love, I've pulled reference from that on multiple occasions. We have one final question. Are there clinical studies that you're aware of that directly link less medications with better patient outcomes?
Oh, yeah. There's lots. Shannon Brownlee wrote a book called Overtreatment. There's a book by, oh my goodness, Lance, what is his name?
Overtreatment, what was that?
Yeah, Shannon Brownlee, Overtreatment.
Overtreatment, I see, okay.
There's a book, God, I can get you it. It's he's written a lot. He actually is a VA doc, but he's an expert on the overuse of medications and inappropriate use of medications. So yes, there's a whole literature on that. There's vast literature on that. There's a literature, for example, and again, I don't have the studies at my fingertips, but there's a literature that shows actually that patients with certain kinds of cancers live longer on hospice when you stop giving too much chemo, that they actually live a year longer. There's a number of studies. I think they are in my book, Wounds of War, because the VA actually has a very robust system of hospice and palliative care. And again, this is a benefit of being in a system where decisions are revenue neutral, because if an oncologist recommends hospice or palliative care to a patient, they lose money, because they're fee for service. And so, for example, you saw the development of hospice and palliative care in the UK in the national health system because it's revenue neutral. And you see it in the VA because you don't lose revenue if you turn your patient over to the hospice and palliative care department. I go into this at great length in Wounds of War about end-of-life care, because I think this is another really critical issue. I don't know how simulation deals with this, but I think that the ability to have conversations and do education about appropriate care at end of life is really important. And that's why, this issue of healthcare disparities is so interesting, because if you look at healthcare disparities as, giving people of color access to more stuff that hurts them, that's not really good. So you have to be very careful about how you look at healthcare disparities. But I think that I would be quite interested in how we can use simulation to have these more appropriate conversations about what kind of care you get, because most of it is just, throwing another drug at a patient. And as we know from the studies, the easiest way to get a patient out of your office if you have a big workload is to give them a script, right?
Right.
And which is why we get so many scripts for antibiotics for colds.
Yeah. And what is that going to do to us long term, right, in terms of our outcomes? So I found the book Overtreated: Medicine Making Us Sicker and Poor, and I shared that link as well into the chat room. So that looks like a really fascinating read.
Like H something, oh my God. And I can I don't know if you have the capacity to.
Yeah, sure. We can update that, into it after the fact. So it doesn't look like we have any other questions, and we've hit an hour here. So I want to appreciate your time, Susan. Thank you so much for giving us this talk and this overview of what's happening and working with the VA. It sounds like there's actually some good news coming out of them in terms of the abilities that they've had, and possibly some changes coming for them in terms of the not too distant future. And so, I really appreciate your insights and your knowledge in not only with the VA, also patient safety and the space of healthcare as well in terms of education and training. It's so important. So again, everyone, thank you so much for participating. Definitely check out Suzanne's website for all of her books and her content. and upcoming webinars. Sign up for her newsletter so you can stay updated with the most recent information and news that she has. She sends out great newsletters as well with regards to that. So folks are saying on the chat room here in Zoom, thank you, very interesting webinar. We see some folks on the website also appreciating you too, Suzanne. So thank you, everyone. Thank you, Suzanne.
Thank you so much. Have a good day. Bye.
Bye-bye.